Okay. Allora, so hello and welcome to our sixth episode of Life with the Author, our initiative of the International Journal of Aesthetic Dentistry, talking to our precious authors. And it's a great honor to have one of my favorite periodontologists with me, Giovanni Zucchelli from Bologna. We know each other for many years now, and I was always amazed when I was looking at your lectures how you go with the scalpel. For me, it's always like looking at Michelangelo or another artist. But I have to tell you, now that I have you here, when I see the blade running under the gingiva, I lose control. And so I think there are some topics or some things that you might explain to us better, because I think not everybody understands what you are really doing when you are below the gingiva. And that's why I selected the topic of recession to talk to you about this. Starting with an article that you published 7 years ago. So I think a lot has changed over the last 7 years. But this is a good starting point to see how things changed over the last years. And we want to also to have an insight or a look what's going on. If you look at these pictures, there are so many ideas and concepts around this technology. So I think let's start right away. And I'm really happy to have you here, Giovanni. So the first question I always ask the authors is the same. So if you had to write this article again, what would you change?
Dear Alessandro, thank you so much for the invitation. It's always a pleasure to stay with you sometimes. And in order to answer to your question, for sure, if I have to write this article about this technique, I would write it in the same way, because the technique, this is a modification of the original two-stage technique, which was introduced by Bernie Moulin many years ago. But at that time, there was, let's say, a big graft that was placed also on the root. And since most of this graft did not heal on the root, so only some of the root was covered, the remaining amount of keratinized tissue apical was used to be advanced coronally in a second stage. But this was a very invasive procedure because a big graft was used in the attempt to cover the root. So what me and Massimo changed with this article is that we don't have to take such a big graft and try to cover the root, because it's very unpredictable, the coverage of the root with a free gingival graft. But it's much better to take a thinner and a smaller in apical coronal direction graft to place it only apical on the periostal bed, so it will heal for sure because it's vascularized. And this is very minimally invasive for our patient compared to the amount of graft that Bernie Moulin was used at his time. And then in the second stage, you advance your grafted tissue in a more coronal position. So since the amount of keratinized tissue you graft is the same amount of keratinized tissue of the adjacent teeth, when you advance the flap, you also achieve a realignment of the mucogingival line, which is another aspect that is very important, because when you make a free gingival graft, it's very unpleasant, it's not so aesthetic to see the very big disalignment of the mucogingival line. So the technique is always in two-stage, but from a patient and aesthetic point of view, I think it's an improvement because of the less patient discomfort, because the smaller amount of graft taken from the palate, and the best aesthetic outcome because of the realignment of the mucogingival line. So I would write the article exactly in the same way. And this is an article or a technique that was extremely successful. I have many colleagues who did many courses with me that asked about this technique, because the lower incisors are the nightmare for the periodontist in terms of treatment of gingival recession. It's an area with a lot of friendly, lot of muscle tensions, very, very shallow vestibulum depth, very, very poor amount of keratinized tissue. So this is a very difficult area to be treated. But obviously there is the drawback of the two-stage, which is exactly the same of today. The two-stage procedure is this one. Also today. I don't hear you anymore.
Oh, sorry, Giovanni. I muted myself because I want to. Yeah, sometimes it's better to mute myself and let you speak. You know. So there was a question: is a thick blood clot underneath the gingiva, which is coronally placed, helpful in achieving better gingival phenotype?
Yeah, that theoretically yes. Theoretically yes, because you know when you have a thick blood clot, this blood clot can also become with time connective tissue. But thick blood clot, in terms of treatment of a gingival recession, it's also a risk factor for the shrinkage of the flap, because we need a very tight adaptation of the tissue to the root in order to avoid flap shrinkage. That's why instead of taking blood clot by itself, we most of the time have to add a connective tissue graft, which is a connective tissue already mature. It's a blood clot after 4 months, let's say, but it's not so unstable, it's not so thick, which can make some trouble in completely cover it by the coronally advanced flap. So I like blood clot, but in mucogingival surgery, I think that we cannot rely on blood clot only because the root is prominent and the thickness of the blood clot is difficult to be maintained stable between the soft tissue and the root. So, or you use the connective tissue graft, or if you have a good amount of keratinized tissue, you can also use a collagen matrix, which is a stabilizer of the blood clot.
Okay, I see. So the literature shows a variety of protocols. So we started this two-step protocol. In the old days, a lot of people did just coronally advanced flaps and hoping that the recession will be covered. So what is your strategy, or are you following the adapted or new rules on?
I think that things have changed in the last years in terms of numbers of techniques that we use. Once upon a time, there was many techniques, and this was probably because we were not happy or so happy about none of this. Today, I think that most of the gingival recession can be treated with one surgical procedure, that is the coronally advanced flap plus the connective tissue graft, or not if there is a good amount of keratinized tissue. And this is for sure a technique that have substitute many other approach, bipapillar technique, laterally move flap, but it depends on the skill and on the area of the mouth, how easy it is to perform the coronally advanced flap. There is areas which is much easier because there is much more vestibulum depth, more amount of keratinized tissue, less muscle tension, and there is areas where the coronally advanced flap is extremely difficult to perform, and this is the lower incisors in particular. I have to tell you that there is, as an alternative, also the tunnel procedure. That is a technique that I don't like so much because I don't think that it gives anything more than the coronally advanced flap, while the opposite, the coronally advanced flap, allows you to treat some gingival recession that you are very, or let's say you are not in my hands, I'm not so predictable to treat them with the tunnel procedure. The tunnel procedure, the amount of advancement of the flap is limited by the shape of the papilla, by the possibility to roll the papilla, and so there is a limited amount of advancement of the flap. So if you have a very deep gingival recession, most of the time you need to leave the graft exposed, and this is something I don't like so much. So my technique of choice is the coronally advanced flap with or without connective tissue graft. But I have to tell you that today the only alternative, true alternative, is the tunnel procedure.
You have to unmute me. So the tunnel procedure is also called the less invasive technique. Although
yeah, it depends. It depends. I know. It's very nice because, it's less invasive for the operator maybe, but not for the patient, because what the patient is really worried about is the amount of graft you take from the palate. When you treat gingival recession, only you have to propose to your patient treatment of gingival recession. The first thing that the patient asks you is, do you go to the palate? And how much or how painful is the wound in the palate? And so I think that the technique that allows you to minimize, or most of the time to avoid, but for sure to minimize the apical corner and the thickness of the graft is a minimal invasive technique for our patient in terms of post-operative course. Obviously, it's more difficult because you have to advance the flap, you have to get the flap completely free, you have to make it completely no tension in the lower incisors, very difficult to achieve the verticalization of the flap, and so it's more invasive for the surgeon. But, it's a question of skill.
Yeah.
So invasiveness, I don't like that people speak about invasiveness, because invasiveness is something that you have to ask your patient, and you have to control how many pills, anti-inflammatory drugs the patient take, or what is the pain by using the same technique also into the palate. And if you look at the amount of graft that people use when you make the tunnel procedure with respect to the amount of graft that I use when I make the corneal advanced flap, you have the answer.
It's like people talking about minimal invasive implant dentistry. I like that very much. So there was a question related right to the topic about graft. So why do we need a graft? I heard, or like the comment of this colleague, why don't we use collagen matrix? Why don't we use other materials?
Yeah, it depends if you use the corneal advanced flap. If you use the corneal advanced flap, it depends on the baseline amount of keratinized tissue you have in your flap. If you don't have keratinized tissue, or if this keratinized tissue is extremely small, less than 1 millimeter, you have to use the connective tissue graft. No alternative. Because the connective tissue graft is used instead of the keratinized tissue of the flap to give stability to your flap. While if the flap has from 1 to 2, so small, very, very thin, but good height of keratinized tissue, the use of the matrix is recommended to increase soft tissue thickness, which is the key for the long-term stability of root coverage. So there is great space for the use of the matrix, and there is great space for the improvement that we are expecting in the future. Because I hope that once upon a time we can say that there is a matrix today that can substitute the connective tissue graft. But this is not true, because it mainly depends on the amount of keratinized tissue of the flap. The matrix is something that will become connective tissue with time. But if this matrix becomes exposed, this don't have enough stability to remain and to maintain the coverage of the root. So we need some improvement also from the company.
Okay, so I see some biological parameters cannot be modified by any artificial gadgets or whatever.
Especially the connective tissue from the palate. It's something that it's so unique. It's so stable. It's so, it's really something that is not easy to reproduce. And I'm not sure that we will be able also in the future, but we will try.
So there's another question related to this: how to avoid formation of a mucosal pouch after free gingival grafts?
I don't know what is mucosal pouch. If you think about the, I don't know what you mean with mucosal pouch.
We have to ask the colleague if he can be more precise on that, because I also have I would have to translate. My English is not that good.
No, it's not a problem of English. I don't think it's the right term. Maybe is the difference in color, texture, and surface characteristics between the graft and the adjacent teeth. There's nothing you can do. You have to pray. Okay. You have to pray a lot. Pray that it's not so different. That's why.
After healing in the apical area.
Yeah, it depends. Again, if you use a free gingival graft that is very big, obviously, because you want to cover the root. You have a big disalignment of the mucogingival line. And so, yes, some scars is formed at the level of the vestibulum, which is something that the patient don't like. There is also food accumulation, etc. That's why I introduced the modification of the two-stage, because in the first stage, there is the pouch, as you call it. So there is a very disalignment. But once the graft is advanced coronally, this will completely disappear, and you have, again, the verticalization of your vestibulum. So the free gingival graft, it's something that for sure is not a good technique for root coverage. It's only a technique that today is used to increase the keratinized tissue around implants in the molar area, or in also in the frontal area in patient with full crown restoration, or let's say when there is no keratinized tissue at all. But the only indication for the free gingival graft today is to increase the keratinized tissue around the implants, not teeth anymore.
Okay, so good. So a lot of dentists are afraid to start with this technique. It's different in implant dentistry. I remember when I started with dentistry, I had to go for 2 weeks to Sweden. Then I came back, and for my 10 first implants, I had a doctor and a nurse from Sweden assisting me. So it was really controlled. You had to learn. Today, the implant workshop is not even 2 or 4 hours, and then you know how to place implants, to be a little bit exaggerated maybe. But how is it in periodontology? So where should a young dentist or even an older dentist start when he thinks, well, this could be a new field of work in my office, because there are many patients with recessions. Most of them, they don't want that you touch anything, because if they don't have pain, if they clean that, or if they don't see it, they don't care about. But where would you start? So what are the basics you need, or where should you go? Should everybody go to Bologna to learn periodontology, or to other schools? There are a lot of schools. So by the way, there are many courses in schools around the globe. But what would be your recommendation for an unexperienced dentist or a young dentist?
I have to tell you that it's true. Once upon a time, to learn periodontology, you have to study a lot, many years. While to make implant, maybe you can only study 2 weeks. And this is something that is completely absurd, wrong. Because I think that implant therapy, especially today, is not the same implant therapy when implant started. So today, patient has incredibly high aesthetic demands. And even if there is no aesthetic indication, but patient wants to have a good outcome, the implant is not covered by a denture, that the patient don't see it. Today, most of the time, implant, it's in a patient with other teeth, and they want that the implant is the same of the adjacent teeth. So they don't want to see difference. So now, to be a periodontist, it's, in my opinion, almost necessary in order to succeed in this type of implantology. So I don't see so many differences. But for sure, in periodontology and periodontal surgery, it's something that needs a long training from the biological background that you need to have in order to be a periodontist. You have to know everything about the periodontal tissue, periodontal disease, how to teach patient to clean and to keep the teeth healthy, etc. But in terms of mucogingival surgery, which is one of the most complicated surgery that we have in periodontal surgery, for sure, there is also a learning curve. A learning curve means that you have to start with the gingival recession that are easiest to treat. For example, upper canine. You have to start with an upper canine, single gingival recession in the upper canine or upper premolar with a good amount of keratinized tissue is the first tooth to be treated. Then you can move to multiple in the upper jaw, where there is a very, very standardized surgical procedure that allows you to treat many gingival recessions in the upper jaw. But everything in the upper jaw is very easy or much easier. Then you move from the upper to the lower jaw. But when you move to the lower jaw, the first tooth to be treated is the lower canine, which is safe, because the lower premolar or the second premolar is not so safe, because there is also the emergence of the nerve. So you have to make another technique in the premolar area compared to the canine. And last, but really last area to be treated is the lower incisors. So I can really suggest people to start and to make this, let's say, progressive, increasing in difficulty in treatment of gingival recession, and they have to follow this advice, because if they start with the lower incisors and they fail, they stop to do it. That's the main problem, because the risk of failure in the lower incisors is very high. While if you start to make easy treatment in the upper jaw, upper canine, upper lateral, upper premolar, you start to, let's say, feel the tissue, also in the same patient, even if the patient asked you for the treatment of lower incisors as first, you don't have to do it. If there is other recession in the mouth, you have to treat the other, because you feel how the tissue of this patient are when you make surgery. You understand how the patient is capable to maintain the outcome with time, because the lower incisors, you need a patient that should be extremely motivated in order to keep this area under a completely control from any trauma, from plaque during the post-op. So there is really some rules that I think it's very important to suggest people starting the adventure of mucogingival surgery.
So what we see in other disciplines also, go back to the basics and learn the basics. As I saw, for example, some so-called perio specialists, and I asked them to do a scaling and root planning, and they were not able to do this.
That's the most important thing that you can say. That's the most important. That I didn't say it before, but it's the most important of all. For example, in Bologna at the university, during the first year of the university, which is the fourth year, the study of stomatology, they only make scaling a root plane for 1 year. That's absolutely, you cannot be a periodontist if you're not able to make scaling a root plane. You cannot be.
I agree, completely agree. There's another question related to what we talked about, tunnel technique, Miller class 3 or 4. So this colleague told me I see some improvements in the tunnel tech, but how can we achieve this with coronally advanced flaps?
Yeah, there is a recent article that I published together with the Michigan University School that shows how also the coronally advanced flap can be used in the treatment of gingival recession. And I try to explain in 2 words. Yes, if you have papilla loss, the papilla don't reach the contact point, that's for sure. But it's also true that if the papilla don't reach the contact point, the papilla is more flat, so more large. So it means that you can extend the desepithelialization towards the palatal and the lingual aspect, and so you increase the area that gives blood supply to the surgical papilla. So this is exactly the same thing that we do when we treat gingival recession around the implants. We extend the desepithelialization of the papilla towards the palatal and the lingual aspect in order to increase the vascular bed for the surgical papilla. And this allows you also to cover the Miller class by Miller class 3, provided, that's for sure, that you have to add the connective tissue graft, because also in this case, the connective tissue graft, thanks to the increase in the thickness, promote the further creeping. So even if you don't cover immediately, with time, the increase in the thickness and make creeping, so further coverage of the root with time.
Cool. So I think now is time to show the short video you sent me. And Giovanni, I removed the sound so you can comment directly what we see. And
so this is just to show you the last step. So the coronally advanced flap in the lower incisors, when you have frenuli everywhere, you have a frenulum lateral, 2 frenuli, apical. So with some improvement of your skill, so not the first gingival recession that you are going to treat. You can also, in one surgical step, treat deep gingival recession in the lower incisors, get rid of frenulum, and increase vestibulum depth, and achieve a very, very good aesthetic outcome with no pouch, so with no difference in color and scars formation in the most apical aspect.
So let's start the video, and you can comment.
So this is the key, is the elevation of the surgical papilla. Look at the frenulum that there is at the level of the papilla, but you will see that during the flap elevation, this is called split thickness elevation, which is done by keeping the blade parallel to the external surface. Look at how many frenuli are also present apical. This is the so-called superficial incision that remove the all muscles from the flap. So in this moment, I'm removing also the frenulum from the flap. This is the removal of the submucosal tissue, which means that I remove the muscles from the periosteum. This is called desepithelialization of the papilla, which is mainly performed with microsurgical scissors. This is the free gingival graft that is desepithelized extraorally, and you can see how thin graft today we are using. This is the very thin suture material, PGA 70, that we use to fix the graft. Look at the small dimension of the graft compared to the recession, the advancement of the flap and the closure, but look, the verticalization. You can see how the flap at the end of the surgery was really vertical, restoring the vestibulum depth. And you can see that there is complete coverage, but also no difference in color and texture with respect to the adjacent teeth. And obviously, compared to the two-stage procedure, the best advantage for our patient is that everything is solved in one surgical procedure.
But as you stated, I think this is not something for beginners.
No, this is the last step. I think that when you reach this level, you can also avoid to use the tunnel. This is for your friends.
Yeah, I like this was a good comment.
Next time, I think that you have to invite two people together in order to discuss the tunnel together with the coronal advanced flap in the lower incisor. I think that this will create such a big audience that you cannot imagine. It will be a disaster.
So-called small things.
Yeah, but they are all friends of mine, so no problem at all. Different approach to gain the same goal, patient satisfaction.
Absolutely. One colleague was asking to share the name of the article that you were citing. Maybe you can also add a comment later if you want.
I think that my name is the first one, was published on Journal of Perio, and the last name I think was there was also Tavelli, Lorenzo Tavelli, and Homlai Wang, but I don't remember exactly the title.
So we will find out.
It's not only for third Miller class. It was general indication for the coronally advanced flap, which was also extended. There is also one case or two cases where there is the coverage of Miller class 3 with loss of papilla height. I don't remember exactly the date, but it was very recent, last year, I think.
Because you're writing a lot of articles, so we might get lost. So
I'm old.
No, and I'm also happy that you are part of the editorial board of our journal, the International Journal of Aesthetic Dentistry, and one of the all people that I have invited so far are like main contributors. So in the future we will also look for younger blood to be.
I think this is a wonderful journal for young people who wants to start to make them, let's say, or to show people all over the world how good they are, because it's an incredibly good quality of pictures, very, very high quality of publication, clinical publication. So it's really a journal I can recommend for people who wants to make them well known, let's say. Not famous, because we are not famous at all, but in terms of dentists, it's a very, very good way of making people know that you are a good clinician.
So that was always the goal. That's why also your work is published in the journal. But again, we also want to motivate young people to come to try to get to that level. So because only if you show a high level of clinical skills, of clinical quality of documentation, this motivates people to go there. I always tell people, I'm not able to be Pascal Magne, but I want to try to be 80% of Pascal Magne, and then you're already good. Or I would love to be 75% of you, and then you're then I'm already good. So no, but because first thing, you cannot do everything 100%. So that's also a message in the journal. It's also for young people to find what they like to do. So some people go to surgical procedures, so they become periodontologists or implant specialists, and others love more to work with composite. They then become Federico Ferraris, Roberto Spreaficos, Didier Diecis, and Newton Falls, and whatever. And so this is important also for the young people, the message to find your way. Don't try to be the best in everything. So I'm sure that you're
I am a supporter of this. Even if I can also understand that for young dentists today, it's not easy to say I only do periodontology, because they also have to survive, they also have to work, and they also have to earn something in order to make courses or to improve themselves. But I absolutely believe that there is no way to succeed in everything. Absolutely, there is no way. And I think that collaborating with other people that do things different, or other things, it's also very motivating. It's very important. And you see that the outcome most of the time depends on interdisciplinary let's say, work. And this is very important, I think, because today it's difficult that only one thing is enough to make the patient happy. You have to make a good restoration, you have to make good crown length, you have to make good posts sometimes, you have to make good endodontic, but you don't have to do everything. You have to select which is something, what you like more, and then with other young people, you have to join together in order to make a very good team.
So you see also the development, what let's say in America, in the United States, the specialists are something that is there for decades. So they had this the general dentist and the specialists, and in Europe, I think this is developing more and more. That dentists of different specialties work more together. To solve problems in this so-called interdisciplinary approach, or you can call it however you want, but that you know where your limits are, and then you try to find a group of colleagues around you. So I suggest that also to young dentists. Try to create a network with colleagues and where you know that you can call them to ask for an advice, or where you can send a patient. I think too many dentists are not sending their patients away too late. When it's too late, when the tooth is lost, they send it then maybe to your university and say, please, Giovanni, save my tooth. And then you tell them, well, it's too late. We should have started with this 10 years ago. So like your article, you wrote a very nice article about treating a hopeless tooth. So I remember this article where you try to save a tooth that 99.9% of other dentists would have extracted immediately, and you saved the tooth for several years. So these are all things that are important to me and also for the community. So
I think that the specialization, it's something that is not the term, but in order to be much more concentrated in one or two topic maximum, it's something that you can do. I think that in my life, I'm very happy that I'm not only a periodontist today, but I also do implants, because I think that implant therapy is something that you can do extremely well if you have much more knowledge, not only in perio, but also in prosto, etc., etc., etc. And you cannot do everything, obviously. But the collaboration between the restorative dentist and the surgeon becomes so evident when you make implant therapy. That is the time that you absolutely understand that you cannot do everything.
Okay, so there were some more questions, but I think we will stop here. I want to thank you very much, Giovanni, for taking your time. And we hope that these difficult times will be over soon, but we don't know, and that we will meet in the future. Next year we have the European Academy meeting. We don't know if this will happen or not. There are many online courses, online workshops, but what you showed us today, so these are things that we need to train with our hands. So we are really eager to see and wait to get again back to normal life and back to normal training. So for example, this week at the university, I was supposed to train with the students, and they had 2 students which were corona positive. So the whole thing was canceled. So especially for the students, it's a very difficult time these days. So, but again, thank you, Giovanni.
I think that webinars, it's a way that we have to, where we can give something to our student, even in this really bad period.
Yes. So thank you, Giovanni, for giving us some insight.
So much. Thank you so much.
So have a nice evening. I want to remind you, we have our group on Facebook. We also have an Instagram account where we want to be more active over time. We will continue with our live with the author interviews. Thank you, Giovanni, and see you soon. Bye-bye.
Ciao, Alessandro. Bye-bye. Ciao.